Awesome. Hi, everyone, and welcome to our new Explore MedTech seminar. This is our special series that we're doing where we're looking at inviting clinicians to these seminars to talk about technologies in their practice. My name is Adnan Saeed. I'm the director for the MedTech Talent Accelerator program. So just housekeeping rule is we get started, please kindly keep your mics and videos muted as we are live streaming and recording this seminar. Once we're in the Q&A, you can unmute and we will get off the live stream and you'll be able to directly ask your questions to Dr. Rod here. So before we then move forward with the seminar, I would like to just acknowledge the land we're on here in Toronto. So Toronto is in the Dish with One Spoon territory. The Dish with One Spoon is a treaty between the Anishinaabes, Mississaugas, Haudenosaunee that bound them to share the treaty and protect the land. Subsequent Indigenous nations and peoples, Europeans, and all newcomers have been invited into this treaty in the spirit of peace, friendship, and respect. And we look to run our programming with that respect that we do here for the MedTech Talent Accelerator. So without further ado, I do want Dr. Rod to have all the time to kind of give his presentation and a chance for Q&A with the participants here. So I will pass on. I will introduce here Dr. Kevin Rod. He's a clinician and runs a prominent pain clinic here in the Toronto area. And is also a fabulous research collaborator with the Faculty of Science at Ryerson University as well. So with that, Dr. Rod, if you want to give a brief, further detailed introduction of yourself, and the floor is yours. And whenever you need to ask for the slide to be changed, just say next slide, and Mary Susan will do that for you. So go ahead, Dr. Rod.
Sure, thank you, Adnan. Hello, everybody. As Adnan mentioned, I'm a family physician with focused practice in chronic pain management. For the past 20 years, my practice has been focused on chronic pain management, which is management of chronic conditions causing pain that are non-cancerous. And also, at times, we have to treat cancer pain cases, but mainly subject of our specialty is related to chronic non-cancer pain management. I was requested to put together a presentation to present the application of technology in our daily practice, which is an interesting topic. When I look at it, there are three areas that we use technology in our practices. One is to diagnose the cases that we have to deal with. The other is how to treat them using technology. And the third application is research. So the sequence of these slides that I'm going to go through are going to be based on that. There will be mostly focused on diagnostic application. Then we'll talk about some therapeutic applications, and at the end we'll talk about research as well. So next slide, please. The first group of technology that we'll talk about is X-ray. As you know, we use regular X-rays or plain X-rays, radiographs, or the name of the pictures that we use. We use them regularly in order to find out after physical examination if you want to get more information about the texture of musculoskeletal system. Mainly, we use X-ray in our practices. X-rays are used in hospitals or other medical practice for other reasons, for example, internal organ evaluations, evaluation of lungs and heart or abdomen, but in our practices mainly used for imaging the joints and bones. Accounts for about 75% of imaging examination. And in this technique, basically an X-ray beam passes through the patient, and the X-ray is absorbed in different amounts by different various tissues. And because each tissue has a certain different density, and the way X-ray will pass through it and then be reflected or absorbed by a special film that will then later on be processed and show the picture. The difference between density of the tissues will be the difference shown on the film, on the image. Next, please. So when we look at the image, we can see that the higher the density will be the brighter the result of the image. And the lower the density would be the lower the result of the image. And the higher density, the highest density obviously is the bone and the lowest is the air. So when it's air, because the X-ray is not being absorbed a lot, when it hits the film, it changes it to black. But when the density of the tissue is higher, for example, if it's passing through the heart, soft tissue, or if it's passing through the bone, relative to the amount of density of the tissue, there will be difference in the absorption. So, for example, the fat generally is gray and darker than muscle or bone. Water, blood, or soft tissue, gray or lighter than fat. And bone, because there's calcium, the absorption is high, and it has the most level of absorption. If you have metal or any other type of highly dense matter, it will be shown as dense white as well. For example, a metal in prosthetic after surgeries, if you want to evaluate the state of the prosthesis that is put inside the body, they take the X-ray and it can show the state of the prosthesis based on the density of the material that is used. There are sometimes that there are cannula that use are plastic, it will be less dense and less white. And if it's a metal, it will be more dense and more white. Next. As mentioned, X-ray is generated by a generator, passes through the body, and is absorbed by a film, a special film that will be then processed and will show the image. And it's usually, it will end up being a two-dimensional presentation of a three-dimensional object that we want to evaluate. And the terminology that used is based on the anatomical position, APPA, or lateral. Next. CT scan uses the same method of imaging, but by different application and processing method. Basically, it's X-ray that is used, so the same rules apply related to the density of the tissue and density of absorption. But it's generated by passing through a rotating fan beam of X-ray through the patient and measuring the transmission at thousands of points. It basically rotates and gives the X-ray from different angles, and then the computer processes all of these images coming, and then it is shown in the form of slices. The radiation is higher than the plain X-ray, but the image quality and the information that we get is much higher than the plain X-ray. Next slide. Basically, we can divide the densities of the tissues that are imaged by CT scan into 4 different categories. Air will be shown black, the same as the radiographs, and fat is dark gray, soft tissue is light gray, and bone or calcium are having the highest density, that they show the highest contrast. So it is similar to the X-ray, but it shows higher details about the tissue that we are evaluating. So sensitivity of CT scan compared to X-ray allows areas with tiny, very, very small amount of punctuate calcification to be seen. Next. So the picture will be shown as a series of slices of tissue. The method is similar to principle of slicing a loaf of bread. Basically, it goes by slice by slice by slice. It's as if you're looking at a slice from a different angle. And the way the tissues are presented are exactly the same that anatomical position are in a body if we cut the body into slices. And again, it's a two-dimensional display of a two-dimensional information that's coming from a three-dimensional object that we are evaluating. Next. Ultrasound is another technology that we use. It's basically, it's the high-frequency sound waves that will be emitted through an applicator or transducer and through a conductive medium, usually gel. It will basically pass through the gel, pass through the body, and it goes through different parts of the body based on their different densities. Again, levels of absorption are different and reflection are different, and the transducer become a receiver as well. And based on the difference between the sound rays that are emitted and sound rays that are received, the machine generates the picture that we see. Next. Ultrasound are used in our medical practices to evaluate different tissues and different regions. We use them for image-guided procedures, but for diagnostic reasons, we can use it for different tissues. For example, for cysts, we can see them as surrounding, covering with no echoes inside, so they will be shown as black because it's mostly filled with water. And tissues like liver and spleen, they give a picture that is mostly homogeneous, and small echoes caused by the fibrous interstitial tissues like arteries and veins and fibrous tissues or slices of connective tissue inside the organ. And high intensity echoes are caused by calcification, fat and air or metal object inside the body. Next. In ultrasound, images can be very dependent on the operator. The higher experienced operator can, when properly applied, can get higher resolution and better images. And if the operator is not very well experienced or does not use the appropriate setting for the machine, or there is not enough conductive gel used, the resulting image is not going to be as good quality. So it's very depending on the quality of the operator. And the field of view is within the patient is limited because it depends on what penetration level is used for the application of the image that we are using. Usually for, there are different frequencies used for different depth of imaging that we use. And images are usually presented as white and echoes and black in the background. And it takes a little bit of training in order to find out the anatomy that is used in ultrasound. Next. So as I mentioned, the transducer and machine can analyze the echoes of the sound waves that are emitted to the tissues. And we can use Doppler, which is basically technology that can show the movements. When something moves towards the transducer, it shows in red, and when it moves away from the transducer, it shows in blue. And again, it takes a little bit of experience because in our clinical mind, we always translate red with artery and blue with veins. But a vein, if it's being imaged, then and the blood is coming towards the transducer, it will still show red. So all of these little nuances are important when a clinician is using ultrasound in order to have the better image and understanding of the anatomy. And Doppler's analysis shows the moving blood and shows the velocity of it. At times when there is obstructions or restrictions of flow, that is very helpful for us. For our purposes, when we are doing injections, it's important for us to know the perfusion and circulation in that region. So when we do injection, we do not do inadvertent intravascular injections. And we can use ultrasound for both anatomical and also use for perfusion. The difference and superiority of ultrasound compared to, say, CT scan or X-ray is that we can use it in movement. So we can, for example, in shoulder, we can use for diagnostic when there is a tear in some part of the tendons of rotator cuff. We can move the shoulder from different anatomical position and show if there is impingement of the tissue. If the tissue is caught, then the tissue is moving. We can see that, while in static type of imaging like in X-ray and CT scan, we cannot. So that's the superiority of ultrasound. Ultrasound is a cheaper machine and it's mobile, so we can use it in the office in different rooms. These are superiority of easy of use in ultrasound that the other larger scale techniques, machines, they don't have these superiorities. Next. MRI is another diagnostic machine that we use. It generates image by applying a varying magnetic field to the body, and magnetic field aligns the atoms. When the field is released, radio waves are generated, and based on the receiving radio waves, pictures are generated by the computer. The frequency of the emitted radio wave is related to the chemical environment of the atoms as well as their location. Basically, based on the anatomy and their density of the molecules and atoms, there are a variety of different reflections that would come. And based on that, the computer will generate the picture. With computer analysis of this data, MRI images are generated, and it can be very helpful when we want to evaluate the soft tissue in more detail, especially the nerves and relationship between the discs and nerves. Those are important in our practices. It's for nervous system. It's a very good machine, and that's very applicable to our diagnostic application. Next. There are two basic types of images that are generated by machines, T1 and T2. And T1 images show fat as white or bright signals, whereas water or cerebrospinal fluid or CSF is shown in dark or blood. On a T2 image, it's reverse. Fat is dark and blood, edema, and CSF appears white. Calcium and bone are difficult to see in MR images, while in CT scan, we see basically the harder tissue like bone better. And in MRI, we see the soft tissue like muscles and nerves and tendons and ligaments better. Next. The advantage of MRI is that it obtains exquisite image of the central nervous system, as I mentioned, and stationary soft tissue such as knee joint. It does not have ionizing radiation, while in CT scan, we use something about 100 times more radiation than the X-ray. So the radiation is always an issue, especially in younger patients. We do not want to expose them to ionizing radiation if it's not necessary. The disadvantages is that artifact caused by patient can be damaging to the resulted image when the patient moves, and the inability to bring ferrous objects near the magnet because it will move, and if the patient has metals inside them, it can be quite dangerous, and machines are very expensive, and it needs expensive infrastructure in order to establish the MRI in a facility. Next. In nuclear medicine, we inject the patient with a nuclear material, and then we evaluate the radiation emitted from the patient. Images are made by giving the patient short-lived radioactive material, where, because it's, the short-lived will help to get the radiation coming out of the patient. And radionuclide decay that happens rapidly with short half-lives will help for radiation to come out of the body, and then concentration of the radioactivity can be imaged and measured in the area of the organ that we are evaluating, and based on that we get an image. It can show absorption, like when we are evaluating, for example, glands like thyroid or lungs or bone or heart. We can see how much absorption has been there. That will show us the perfusion. That will show us indirectly inflammation, and it can be both for a structural and functional evaluation. Next. Images are made by gamma camera or positron emission scanner that records the radiation emanating from the patient and makes an image of the distribution. These pictures that you see here are showing the whole body scan, and the musculoskeletal system are shown, and then you can see that some of the absorption in the bladder and in the kidneys is quite a collection of the radioactive material in these regions. And in musculoskeletal areas, when we have inflammation, we have a higher concentration. So that's an indication of inflammation in that joint, and then we can apply appropriate treatment based on that. Images are usually obtained as planar images that like plain X-ray display three-dimensional data in 2 dimensions. So it's like It's a plane X-ray. It's not, it's a planar images that are not three-dimensional. They are indicative, as I said, about both the structure and also perfusion. Next. There are some advantages of nuclear medicine and its ability of obtaining image of physiological function. Like it shows the secretion. For example, we saw in kidneys and in bladder that the secretion has happened aside from perfusion. There are some, there's virtually no other imaging technique that can show regional pulmonary ventilation or hepatobiliary function, or a secretion of material that are an indicative of the level of perfusion and concentration in different tissues. And that is very helpful when we are making our clinical judgment and diagnosis. Next. EMG or electromyogram is another technology that we use in our clinical practices. Our muscles and nerves work basically based on electrical conduction function. And in order to evaluate the electrical conduction function, we can use EMG for the muscles. And there's another test called NCV, or nerve conduction velocity, that we use in order to find out how the electrical conduction is happening into the tissue. And based on that, we can see how healthy or how problematic the situation of the tissues are. EMG measures the electrical activity of muscles at rest and during contraction. We can find diseases that damage muscle tissues, nerves, or junction between the nerve and muscles, like herniated disc. Herniated disc usually irritates the adjacent nerve and causes a situation we call them radiculopathy or polyradiculopathy. And these tests can show how damaged the nerve are. In conditions like ALS or myasthenia gravis, we can use these techniques to show us the state of the muscles and the ability of the function of the nerves. Next. As I mentioned, nerve conduction studies and nerve conduction velocity. The study measures how well and how fast the nerves can send electrical signals. It can show any damages to the peripheral nervous system, which includes all nerves that lead away from the brain and the spinal cord, and the smaller nerves that branch out of these nerves, like in clinical conditions like in carpal tunnel syndrome or ulnar tunnel syndrome. These are areas where the nerve is passing through a tighter area, and then the tightness can cause issues related to the function of the nerve. And conditions like Guillain-Barré, we can also do these nerve studies in order to find out the function. Next. In clinical practice, we use X-ray in order to do guided procedures. We use fluoroscopy, which emits some level of X-ray, which is not very, very high level of X-ray, that will give us a very nice image of the soft tissue and bones and joints. We use X-ray to help doctors precisely point needles and other instruments during the surgeries. It helps accuracy of the procedure. It improves the outcome, increases the success rate because we know the anatomical positioning of the tissue and also the needle positioning better. It increases patient satisfaction, diminishes risk of complications of inadvertent injections into other tissues other than the tissue target that we want to use, and reduces the number of treatments necessary because the outcome improves. Next. I've used also ultrasound in order to help us to do ultrasound guided or image guided injections. We use them in order to see the needle when we are approaching the target. The blind injections have less accuracy compared to the conventional palpation anatomical landmark guided injections. Using ultrasound will help accuracy of the injections. It usually has been shown statistically that the number of mistakes are less because the anatomy is being seen. And again, appropriate training and experienced user is needed in order to have the best result and outcome. And next. Another technology that we use is RFA, or radio frequency ablation. There are times that we have sensory nerves that are sending signals of pain to brain from the damaged tissues, like a damaged joint that is not ready or not does not have the indication for surgery will be a source for sending pain signals to brain. The same thing can happen in the spine. If we have facet joints or joints that are degenerative or arthritic, they are generators of pain that are sending pain signals to brain on an ongoing basis. Because we cannot fix the tissue, we cannot change the knee yet if the patient doesn't have the indication, or we cannot, for that matter, change any of the spine facet joints. We need to burn the sensory nerve. These are nerves that only send sensation, and they're not motor nerves. So burning them will not cause any motor nerve deficit. So we use electrical current to generate radio frequency, and that when exposed to the tissue or the nerve that we want, basically we put the probe adjacent to the nerve, and the heat generated will burn the nerve. And the pain signals will not be able to go to brain through that nerve anymore, because the nerve is basically killed. The nature is smart. After about a year or 2 years, brain figures out that the signals are not coming from that region, and the regeneration of nerves will happen again. But then we can use the same technique of radio frequency ablation for that region. And then, if a person who is suffering from this pain has to do this procedure once a year, once every 2 years, they are quite happy to do that, because during that time they will not have the pain that is causing them a higher level of suffering. Next. So we talked about diagnostic applications of technology in our practices, and also a few of the therapeutic applications in my practice, which is basically using image in order to give us guidance to do procedures or use technology to burn nerves. We discussed those. Now I just wanted to briefly talk about application of technology in research. Many of the clinical settings, my clinic is a community-based clinic, but we have we are a teaching center also for University of Toronto for their medical students. I have also research affiliation with Ryerson University in the form of joint research that we have. So in different clinical settings is basically where the research is happening, or basically try to link the bench to a practice through application of science and technology for medical practice. And the project that we have is trying to open the way for targeted treatment. One of the things that we suffer from in our clinical practice is that most of our treatment are not targeted to the exact target that we want to use. In many cases, we have to take oral medication or IV injections that will circulate through the body, will have the side effects for the whole organism until it gets to the target of the treatment. So we need to have higher level of medication and exposure of the patient to higher level of side effects. If we can apply effective treatments right to the target, it would be hopefully better treatment outcome and less systemic side effects. In this case, we are trying to load nanoparticles with therapeutic agents in order to deliver them by use of low-level energy of ultrasound emitted to the target, where these nanoparticles would release our desired therapeutic agents that have been previously loaded on them by the use of the heat or mechanical energy from ultrasound to release the medication to the target. Now we are envisioning two targets. One is the cancer tumors, and the other is the pain targets. And we have done basically the in vitro studies, and we have been, next please. we have been successful in having authorization for ethics board approval for starting animal studies that will be starting early next year. And our hope is to have some new nanomedicine that will have a novel method of delivery to the targets related to cancer and pain. And this was just an example for you to know that the technology can be used for opening the new ways and new horizons for generating new medications and new modes of delivery in order to enhance our efficacy of our treatments and reduce the side effects to the patients. I hope that you found this whole explanation of application of technology in my practices helpful.
Awesome. Thank you so much for that, Dr. Rod. Really